Now let's look at some important radiographs. How does a coin appear in the esophagus? Remember, esophagus is a muscular distensible tube. When the child swallows a coin, this can appear on a coronal plane on the frontal radiograph. It will appear full on the frontal radiograph. And when you see a side view or a lateral view, remember trachea is anterior, esophagus is posterior. So it will appear slit-like on the lateral radiograph. So on the lateral radiograph, you see it slit-like posterior to the tracheal stripe. So you see the black color trachea and it is seen posterior to the tracheal stripe. This is coin in the esophagus. And if the coin enters the trachea, how does it enter? Remember, we have a larynx and then the trachea. And the larynx has vocal cords. The larynx has the vocal cords. So if the coin has to enter into the trachea, it has to pass through larynx and then into the trachea. So it will go in a sagittal plane in the frontal radiograph. So it will appear in a sagittal plane in the frontal radiograph. And when you see the same thing on a side view, it appears full on in the tracheal stripe within the tracheal lucency. So to explain you, now imagine this is the coin. If it has to enter into the trachea, it has to pass between the two vocal cords. So it has to pass like this. So it will appear slit-like on the frontal radiograph. And if you see it from the side view, it will appear full on. That is coin in the trachea. But if it is in the esophagus, it will come like this on the frontal radiograph. And if you see a side view, it appears slit-like in the esophagus. So if it is in the esophagus, on the frontal radiograph, it will appear full on. And on the lateral radiograph, it will appear slit-like posterior to the tracheal stripe. And if it is in the, if the coin is in the trachea, it will appear slit-like in the frontal radiograph. It will appear full on when you see on the lateral view. That is what is happening. You can see the coin whether it is in the esophagus or in the trachea by that way. And if there is coin in the esophagus and it's an asymptomatic child, if there is a asymptomatic child, would you wait and watch or would you do anything aggressively? Would you want to go for esophagoscopy or something like that? Please remember, if the child has swallowed a coin and he is asymptomatic, you wait and watch. It usually comes out in the fecal matter, wait and watch. But if the child is symptomatic, obviously you would like to remove by rigid esophagoscopy. And if the coin is in the trachea, obviously you remove by rigid bronchoscopy. But on the radiograph, if you see a double rim like this, let me zoom it for you. Can you see the double rim or a double ring inside? So it is not a coin that is there. If you see a double rim or a double ring, so this is how the double ring will appear. Or on the side view, you may see a step off like this. There is a step off or a step down. So if you are seeing a step off or a step down on the lateral radiograph, and on the frontal radiographs you are seeing double rings, this is suggestive of a button battery. So if you see a button battery in the esophagus, you will see this double ring or step off. And button battery in the esophagus is an important emergency. Button battery is a highly alkaline content inside with risk of esophageal perforation, high risk of esophageal perforation with the button battery. So will you wait and watch or will you go for a removal by esophagoscopy? Obviously, you will have to remove by esophagoscopy. Remember, button battery in the esophagus is an important emergency. In the stomach, we have acid, it neutralizes acid. So we are not worried much in the stomach as much as we are worried in the esophagus. So button battery in the esophagus is a more important emergency. You have to remove by urgent esophagoscopy. Remove by urgent esophagoscopy. Are we clear with this? So this is button battery in the esophagus. Now look at this radiograph. What do you see on this radiograph? Please look at the radiograph carefully. Can you appreciate this is the breast shadow on the right side and you're not seeing the breast shadow on the left side. So this is the breast shadow that you have. This is the breast shadow. So you're not seeing the breast shadow on the left side. So this must be a case of left-sided mastectomy if this is a post-operative patient. But if it is a congenital absence of breast tissue, this is called as Poland syndrome. This is amastia and absent pectoral muscle. This is Poland syndrome. Now look at this image. This is how you have the intercostal chest tube, which is placed for treating the pneumothorax. The chest tube is directed upwards, so this is placed for pneumothorax. If it was placed for pleural effusion, it would have been directed downward, but if it is placed for pneumothorax, it will be directed upward. And look at this radiograph. What is this radiograph showing you? I hope you can see this is the cardiac pacemaker that you have. A cardiac pacemaker will have two thin electrodes. You can see the two thin electrodes, one ending in the right atrium and one ending in the right ventricle. So you have two thin electrodes, one ending in the right atrium and one ending in the right ventricle. This is how we have a cardiac pacemaker. And how do you know what valves are these? Which one is the mitral valve and which one is the aortic valve? To know that, we need to draw this imaginary line. This line is drawn from the left auricle, just below the left hilum, from the left auricle area to the right cardiophrenic angle between the heart and the diaphragm, the right cardiophrenic angle. You draw an imaginary line. If the valve is located below this imaginary line, this is mitral valve. And if the valve is located above this imaginary line, this is aortic valve. So you have the aortic valve and the mitral valve. These are the prosthetic heart valves. So this radiograph is basically showing you the cardiac pacemaker as well as your prosthetic aortic and the mitral valve. And look at this tube. This is your endotracheal tube. The tip of the endotracheal tube is more than 5 centimeters above the carina. The tip of the endotracheal tube to aerate both the lungs, it is more than 5 centimeters above the carina. This is a normal endotracheal tube. And this is the tracheostomy tube that you have. And there is a leaf with radiating lines like this. This leaf is called as Ginkgo leaf. Ginkgo leaf. So when you have subcutaneous emphysema, especially along the subcutaneous planes of the pectoral muscle fibers, so you see this radiating lines like this along the subcutaneous planes of pectoral muscle fibers. This is called as Ginkgo leaf sign. This is suggestive of subcutaneous emphysema. This is Ginkgo leaf sign, feature of subcutaneous emphysema. And look at this radiograph. In this radiograph, you see multiple rib fractures. And this patient is showing paradoxical movement of chest wall. The normal movements are this blue color. Normally, during inspiration, the chest wall should move outward, and during expiration, the chest wall should move inward. But after rib fracture, if you see a chest wall which is moving inward during inspiration and outward during expiration, this is called as paradoxical movement. Paradoxical movement. So if you see such paradoxical movement, what is this suggestive of? This is Flail chest. This is Flail chest. Right? So if they give you that description and you are seeing rib fracture and you are seeing this description that the chest wall is moving inward during inspiration and outward during expiration, that is a Flail chest. Now let's understand some important radiographic views. Our occipitofrontal view is called as a Caldwell view. And this is used for the frontal sinus. To evaluate the frontal sinus, we use Caldwell view. Our occipitomental with closed mouth, this is called as Waters view. And this is to look for maxillary sinus. Occipitomental with open mouth, this is called as Rhese view. And this is for both maxillary as well as sphenoid sinus. For both maxillary and sphenoid sinus, we use Rhese view. So basically, Caldwell view is occipitofrontal. Occipitomental with closed mouth is Waters view. Occipitomental with open mouth is Rhese view. PEP, you remember, open mouth is Rhese view. And you can use Rhese view to look at both maxillary and a part of the sphenoid also. By looking at the skull radiograph, how do I know which is a Caldwell view and which is a Waters view? So to identify which is a Waters view and which is a Caldwell view, first look at the skull radiograph, identify the maxillary antrum. This is the maxillary antrum, this black air-filled area, this is the maxillary antrum. On this radiograph also, I hope you can see, this is the maxillary antrum. And once you have identified the maxillary antrum, the next thing that I want you to identify is the petrous ridge. Try to identify the petrous ridge. This is the petrous ridge that you have. This is the petrous ridge. Can you see? This is the petrous ridge. Do not confuse with the zygomatic process. This is zygomatic process. Below that, you are seeing the petrous ridge. So if you see that the petrous ridge is below the orbit, this is the orbit. If the petrous ridge is below the orbit, overlapping the maxillary sinuses, that is your Caldwell view. This is the Caldwell view. And if you see the petrous ridge below the maxillary antrum, this is your Waters view. Waters view. So imagine this thing. This is the squamous part of the temporal bone. Imagine this is the petrous part having all the ear ossicles and all. So when you're looking at the occipitofrontal view, the petrous ridge will be below the orbit overlapping the maxillary antrum. But when you go for a Waters view, that is occipitomental view, the chin will be touching the phlegm. The petrous ridge appears to be going below the maxillary antrum. That is what is Waters view. Petrous ridge below the orbit overlapping the maxillary antrum is Caldwell view. Petrous ridge below the maxillary antrum, right? That would be your Waters view, the occipitomental view. I hope you can pick up which is Caldwell view and which is Waters view by looking at the skull radiograph also. Now, what is a Townes view? Please remember, Townes view is a AP view of the skull with 30-degree angle. So, from the anterior to posterior part of the skull with a 30-degree angle from the baseline, that is what is called as a Townes view. And this Townes view focuses on the foramen magnum and the mastoid air cells and the petrous ridge that you have there. So, you can see the foramen magnum, the petrous bone and the mastoid air cells. This is what is Townes view, AP view of the skull with a 30-degree angle. And what is a Schuller view? A Schuller view is a side view of the skull like this with a 30-degree angle, trying to focus on the mastoid air cells. So, to look at the mastoid, middle ear, cholesteatoma there, the radiographic view we use is a Schuller's view. Schuller's view is a side view of the skull where you are trying to give the X-ray beam at a 30-degree angle to look at the mastoid air cells and the middle ear. And Rhese view. Rhese view is mainly used to look at the optic canal. This is mainly used to look at optic foramen or the optic canal. Now, in Rhese view, you see that the zygomatic process, the nose and the chin are touching the cassette. And you are using an X-ray beam at a 40-degree angle from the mid-sagittal plane. So, this view is called as a Rhese view, and Rhese view is mainly for optic canal or the optic foramen. You can remember it like this, R. Rhese view. This is for optic canal or optic foramen. You must have heard about Illuminati, right? So, this optic canal, you learn this R, Rhese view is for optic canal or orbital foramen. Now, let's quickly review these views. The first one we learned was Caldwell view. What is Caldwell view? It is an occipitofrontal view. This is used to look at frontal sinus. You can also look at the superorbital fissure. So, the frontal sinus and the superorbital fissure in the orbit can be seen by Caldwell view. Waters view is an occipitomental view. Closed mouth or open mouth? This is closed mouth. Closed mouth. And what is this for? This is mainly to look at maxillary sinus, and even we can see the orbital floor through this view. The best view to look at orbital floor fractures is also Waters view. Remember teardrop fracture, bloat fracture that you study in your ENT classes, ENT time. The contents hang into which sinus? Maxillary sinus. So, when you have teardrop fracture, bloat fracture, there is a fracture of orbital floor. So, orbital floor and maxillary sinus, both of them are seen on Waters view. Perry's view is also occipitomental view with open mouth, and this can show you part of the maxillary, and because you're opening the mouth and taking the X-ray, you can see a part of the sphenoid also. Townes view we learnt, this is a skull radiograph which is AP view with 30-degree angulation. And what is this Townes view used to look at? The foramen magnum. You can see the dorsum sella, the petrous bone and the mastoid cells. This is Townes view. Rhese view we learnt is for optic canal, right? So, I had asked you to remember like that. That is your Rhese view for optic canal. Let's look at some other important radiographs. The X-ray view to look at hollow viscous perforation on pneumoperitoneum is a chest X-ray, right? Remember, peritoneum, you have to go for a chest X-ray, right? Because the important finding in hollow viscous perforation on pneumoperitoneum is air under right hemidiaphragm. Air under right hemidiaphragm, and that will be seen when you take a chest radiograph. Hemidiaphragms are seen, the domes of diaphragm are seen on chest X-ray. And only if the patient is erect, there will be air coming upward and lying under the right hemidiaphragm. So air under right hemidiaphragm is seen by chest X-ray, not abdominal X-ray. Hollow viscous perforation, pneumoperitoneum, you have to go for a chest X-ray. Intestinal obstruction, you go for supine abdominal radiograph. The best X-ray view for intestinal obstruction is supine abdominal radiograph. So when the patient is lying supine, the bowel loops will be in the respective fossa. The large bowel will be periphery, small bowel will be in the center. You can know whether it is a large bowel obstruction or a small bowel obstruction. So this is intestinal obstruction for supine abdominal radiographs. Remember, there is no role of erect abdomen in intestinal obstruction. You get a supine abdominal radiograph, you see distended bowel loops, you suspect intestinal obstruction, get a CT scan done. There is no role of erect abdomen. If your patient is standing erect, all the bowel loops are tilted towards the pelvis. You don't know which are this bowel loop that are distended. Is it large bowel or small bowel? But when the patient is lying supine, all the bowel loops are in the respective fossa, right? The paracolic gutters, and you can know whether it is a large bowel obstruction or small bowel obstruction, jejunal obstruction, ileal obstruction better by getting a supine abdominal radiograph. Pneumothorax is better seen on an expiratory film. Imagine there is a small pneumothorax. If it is a inspiratory lungs, the lungs are big, the pneumothorax will be hidden. But if the lungs are small, if there is expiration happening, the pneumothorax will stand out. So to look at small pneumothorax, expiratory film is a better film. So please remember, what is the best X-ray view for hollow viscous perforation on pneumoperitoneum? Chest X-ray. What is the best X-ray view for intestinal obstruction? Supine abdominal radiograph. What is the best X-ray view for pneumothorax? Expiratory view. Remember, we are talking about X-ray views. If they ask you investigation of choice for hollow viscous perforation, pneumoperitoneum, intestinal obstruction, pneumothorax, for all these air-filled areas, what is the investigation of choice? CT. If they ask investigation of choice, that is CT scan. Air anywhere, we generally go for CT scan. But what we are talking here is about X-ray views, the best X-ray views. So look at the clinical history given in the question carefully. If you are having a peptic ulcer patient, worsening abdominal pain, rigidity, and they ask you which radiograph is preferred, you are suspecting hollow viscous perforation, you go for a chest X-ray erect. But if you are given a patient with post-operative patient, abdominal surgeries, now coming with constipation, decreased bowel sounds, distended abdomen, you are suspecting of intestinal obstruction. For that, you have to go for a supine abdominal radiograph. And what is the best X-ray view for pneumothorax? A expiratory view. And what is the investigation of choice? CT scan. Remember, expiratory film we advise whenever you are dealing with patients with small suspected pneumothorax or when you are suspecting a foreign body. We go for a expiratory film. Remember, small pneumothorax, I explained you why expiratory film is used. And even when we have a foreign body in the lungs, you may get a ball valve mechanism. The air may be allowed to come in but not allowed to go out. There will be air trapping in expiratory phlegm. So normally the lungs should become small during expiration. But if the lung is not becoming small, if there is air trapping in expiratory phlegm, so if there is a foreign body, you will see air trapping in expiratory phlegm. So for these two conditions, we go for expiratory phlegm. So normally the radiograph taken is a chest X-ray in full inspiration. The normal radiograph that you take, the most common radiograph that you take is taken in full inspiration, arms abducted. So the scapula moves away from the lung fields and in an erect posture. This is the most commonly done radiograph, the chest X-ray PA view. It is done in full inspiration. When do you do expiratory phlegm? Two conditions. What are they? Pneumothorax and when you are suspecting a foreign body. You will see air trapping in expiratory phlegm. Air trapping in expiratory phlegm. What is the best X-ray view for pleural effusion? To pick up small amounts of fluid on radiographs, the best X-ray is a ipsilateral lateral decubitus view, where you ask the patient to turn to one side. While he is lying on the stretcher, you are asking him to turn to one side. If he is having right pleural effusion, you will ask him to turn to the right side on the bed and you put a film behind, and you don't take a vertical X-ray, you take a horizontal beam of X-ray. So what does decubitus mean? The patient is lying on the stretcher and turning to one side. If he is having right pleural effusion, right lateral decubitus. If he is having left pleural effusion, we go for a left lateral decubitus. Lateral view is different, lateral decubitus is different. Decubitus means he is lying on the stretcher and turning to one side. Okay. Lateral view means he is standing and turning to right side or left side. Lateral view is different, lateral decubitus view is different. Decubitus means he is lying on the stretcher and turning to one side. So you will see the layering of the fluid there. You will see that the pleural fluid is layering like this when you go for a lateral decubitus view. Small amounts of fluid also will nicely picked up on a lateral decubitus view. In a chest trauma patient or a patient who cannot stand and give you chest X-ray erect, like a lower limb fracture patient, ICU ventilated patient, in these patients we put the X-ray film behind and we take a X-ray from anterior to posterior direction, that is a chest X-ray AP view. So in chest trauma, what is the X-ray view that we take? AP view. Routinely taken radiograph is a PA view. The most commonly done chest X-ray is a chest X-ray PA view. And AP view is done when you have a patient with chest trauma or when you have a ventilated patient, ICU patient, bedridden patient, low limb fracture patient who cannot give you a chest X-ray erect. We go for a AP view. Remember few technical factors with the chest X-ray PA view. The film focus distance, that is the distance between the X-ray source and the X-ray film. The film focus distance in a chest X-ray PA view has to be 180 centimeters or 6 feet distance. And what is the radiation exposure? What is the radiation dose that is given on a chest X-ray PA view? Is about 0.02 millisievert. We learned this. So radiation dose of a routine chest X-ray PA view is about 0.02 millisievert. So please remember these two things with the most common radiograph. What is the most common radiograph done? Chest X-ray PA view. What should be the film focus distance? 180 centimeters or 6 feet. And what is the radiation dose on a chest X-ray? 0.02 millisievert. A AP view of the chest X-ray will produce apparent cardiomegaly. Remember A for A, you can remember apparent cardiomegaly occurs in AP view. And it is nothing, it is just optics. Remember, imagine this is the film and in PA view, when you are holding, the X-rays are coming from behind, the heart is very close to the film. So you will see that the heart is of normal size. But in AP view, the heart is anterior, film is posterior. So when the X-rays are coming like this, they appear to form a shadow which is appearing larger. So is it an actual cardiomegaly or apparent cardiomegaly? It is an apparent cardiomegaly. It's just optics that is happening there. So apparent cardiomegaly occurs in AP view. Remember A for A, apparent cardiomegaly occurs in AP view. And you should also understand what is a lordotic view. A lordotic view is when the patient is arching backward like this in lordosis, right? Lordosis. So imagine this is the clavicle and this is the lung apex. So on a PA view or AP view, the lung apex may be hidden by the clavicle. But when you go into lordosis, when the patient is arching backward, this clavicle will move away from the lung apex and you can see the lung apex better. So lordotic view is used for lung apex. And also when you take a deep inspiration, between the upper lobe and the lower lobe, the middle lobe will be obscured, will be hidden. When you go in a lordotic view, you can see the middle lobe pathology is better. So lordotic view is used for looking at middle lobe pathology and for lung apex. For middle lobe pathology and lung apex, we use lordotic view. And what is the best X-ray view to look at the Sella Turcica, the area of the pituitary? The best X-ray view to look at the Sella Turcica is a lateral skull X-ray. To look at the Sella Turcica, the Pituitary Fossa is best seen on a lateral skull radiograph. And also all the sinuses, all the paranasal sinuses, a part of the frontal, the ethmoidal, the sphenoid sinus, right below the sella, all the sinuses can be seen in a single lateral skull radiograph. So if you want to see all the sinuses, part of all the sinuses, you will go for a lateral view. You can see part of the frontal, the maxillary, the ethmoidal, the sphenoidal. So all the sinuses can be seen in one view, that is a lateral skull radiograph. The best view to look at particular sinus is different. To look at frontal sinus, best is Caldwell view. To look at maxillary is Waters view. But if you want to see part of all the sinuses in one radiograph, you go for a lateral skull radiograph. And the best X-ray to look at orbital floor, we discussed the orbital floor fractures, the teardrop fracture, the content hang into maxillary sinus. And the maxillary sinus is seen by Waters view. Orbital floor is also seen by the Waters view. So remember Waters view for orbital floor. We learned this. I told you the tip of the endotracheal tube should be how much distance from the carina? More than 5 centimeters from the carina. A normal endotracheal tube, the tip should be more than 5 centimeters from the carina. But look at this chest radiograph. Look at the endotracheal tube. Look at the tip of the endotracheal tube. Is it above the carina or has it gone into one of the main bronchus? Look at the tip carefully. Let me zoom it for you. Are you able to notice the tip? Are you able to notice the tip has gone into the right main bronchus and is aerating only the right lung and is not giving aeration in the left lung? So this is what is a faulty insertion looks like. Faulty insertion of endotracheal tube. Normally, the tip of the endotracheal tube should be more than 5 centimeters from the carina. If it has gone into the main bronchus, this is faulty insertion of endotracheal tube. And what do you see here? These are your ECG leads. This is ECG leads. Don't consider them to be foreign bodies, okay? These are just ECG leads that you have. Now look at this chest radiograph. It's a newborn with frothing. So if you have a neonate with frothing, and then given this chest radiograph, what do you see on this chest radiograph? If you observe carefully, I hope you can see there is coiling of nasogastric tube. So whenever you have such coiling of nasogastric tube, right, and in this radiograph you can also see air in the abdomen. So when you see coiling of nasogastric tube, think of tracheo-oesophageal fistula. Tracheo-oesophageal fistula. And a distal tracheal fistula, because the lower part is connected to the trachea, there will be a lot of gas in the abdomen. There will be air in the abdomen. If you see the distal type of tracheo-oesophageal fistula, the more common type of tracheal fistula. So when you have tracheal fistula, when you're trying to pass the nasogastric tube, you cannot pass it. You will see the coiling like that. So that is called as the coiling of the nasogastric tube. So coiling of nasogastric tube occurs in tracheo-oesophageal fistula. So that completes our discussion of X-rays. So we understood how a X-ray tube is, what are the different mechanisms of X-ray generation, what do you mean by Bremsstrahl lung radiation, characteristic radiation, what is a Compton effect. We understood what is kilovoltage peak MAS, and we looked at the different radiographic views for different conditions.